All right, folks, thank you for your patience. I think we'll get started. I'm just trying to bring up the next slide. There we go. All right. Excellent. Thank you very much. So welcome, everyone, and thank you for joining us as we start our journey over a series of 5 sessions to cover the 5 steps of evidence-based practice. So I'm Dr. Alex Stevens. I'm the Director of Research at Northern New South Wales Local Health District, and I belong to one of the member organisations of the Rural Research Collaborative Learning Network. Today, we're joined by Dr. Zoe Michaleff, the Research Operations Manager at Northern New South Wales LHD. Zoe will be guiding us through today's session. Sorry, click on the right. Getting there. So to officially get us started, we acknowledge the traditional custodians of the lands and waters where we work and live. We acknowledge the traditional custodians of living culture, their connection to country and their contribution to the life of this region. We pay our respects to the ancestors and elders of the region and to all Aboriginal people past, present and future, and any Aboriginal people that may be joining us today. So welcome. All right, so I'm delighted to welcome you to session 1 of the Evidence-Based Practice Seminar series. So in this series across the next 5 weeks, we'll cover the 5 steps of evidence-based practice, including step 1, which is ask, step 2, which is acquire, step 3, which is appraise, step 4, which is apply, and step 5, which is assess. What we'll do in each session, we'll highlight why each step is important, provide you with the knowledge and skills to be able to undertake each step, and also provide local examples of how each step is applied. We've got a great lineup of speakers who are experienced in research and have a good understanding of the clinical context and the challenges you guys face as clinicians trying to implement evidence-based practice. So we've got myself as the Director of Research for the LHD, Dr. Zoe Michaleff, the Research Operations Manager at Northern New South Wales. We've got our superstar conjoint academic in nursing and midwifery, Associate Professor Christina Agar. So she's a conjoint with Southern Cross University. Equally as impressive as our conjoint allied health academic, split between Northern New South Wales and Bond University, and another amazing academic, Associate Professor Chris Williams, who's a conjoint with Mid-North Coast LHD and also the University of Sydney. So to support you throughout your evidence-based practice journey, we've developed a handy workbook. So this work has been led by Dr. Zoe. The workbook is a resource for you to keep. It's a place to take notes. It also provides some group activities and has some useful templates within. Just a note of caution. So the evidence-based practice seminar series is designed to be introductory, but it might actually seem a little overwhelming for some, especially if you're new to this space or haven't done it for a while. Don't be discouraged by the content. If it does seem a little overwhelming, don't worry about it. The resources are designed in such a way to be enduring, and the content is there such that you can revisit it as many times as you need until you're comfortable with the evidence-based practice principles and concepts. So we're not advising everyone or anyone to learn all aspects of evidence-based practice straight away unless you really want to. Rather, take your time, go back to the workbook as necessary whenever the need arises. Just a little bit of housekeeping. So we're recording the session today, and also we've muted your microphones because we'll get close to maybe 80 or 90 people. If you've got any questions, please feel free to ask questions. Ask them using the chat function, and we'll attempt to answer them as you're asking them. If we do have time at the end of the session today, we'll open it up and we'll try to unmute you guys so we can answer some live questions. Sorry, just bear with me. All right, so in today's session, Dr. Zoe will introduce you to evidence-based practice and cover a number of components or principles or parts. One of these is recognise what evidence-based practice is and why it's important. Describe the elements of a well-defined and answerable research question or question using a particular framework called PICCO, which stands for Population, Intervention, Comparator and Outcome. Identify the PICCO in a published article and apply the PICCO framework to ask your own answerable question. So without further ado, I'm going to hand over to Dr. Zoe, who will guide us through the rest of today's session. Thank you, Zoe. I think you're just muted. Sorry, Zoe.
Too excited. Here I was saying we've got the hang of this technology. Oh, good. Pull back my stuff. Thank you, Alex. And can I just begin by saying that we're very excited to be delivering the evidence-based practice seminar series to you today. And we hope that over today and the next 5 weeks, you're able to learn something new, practice some old skills or refresh some old skills, and overall just become a bit more comfortable in finding high quality research evidence to inform your practice and every decision you make that you do. I'd just like you to take a moment and think about how you make a decision when faced with a problem or uncertainty. And so what you may or may not realise is that you go through a series of steps or a process. First, you identify the need to make a decision. You then generate alternative solutions. You then collect evidence to evaluate each of those alternatives you identified. And when we're talking about evidence, we're really just talking about you're collecting information. And no doubt, when faced with a problem or uncertainty, you're going to collect information from various sources. And then you combine that information and then you use that to make a decision. And at some point down the track, you evaluate the effectiveness of that decision. Was it a good decision, bad decision? What would you do differently next time? And so in healthcare, we call this process of collecting evidence from various sources and combining it to make a decision, we call this evidence-based practice. And David Sackett is recognised as one of the founding fathers of evidence-based practice or evidence-based medicine. And this way of informing decisions has been around since the 1990s. And David Sackett defined evidence-based practice as the conscientious, explicit and judicious use of current best evidence in making decisions about the care of individual patients. And when thinking about what current best evidence is, Sackett identified that the most robust clinical decisions integrate evidence from 3 key sources, these being patient values and preferences, clinical experience, and best scientific evidence. So when we're thinking about eliciting patients' values, preference, and circumstances, we're really talking about collecting information from patients about their preferences, beliefs, and values. We're talking about collecting perhaps some information from collateral, so either patients' families or the place of residence or emergency services. We're considering factors such as time, the time they've got available to attend treatments and adhere to treatments, and also financial considerations. And thinking about clinical experience and expertise, we're talking about your knowledge, skills, and experience. And as the definition of evidence-based practice has evolved over time, increasingly it's recognised that the context, so the setting that you're working in, and the resources you have available have a huge impact on the decisions you make and the care that you provide. Lastly, when we're thinking about the best scientific evidence, we're talking about the scientific literature here. And we're essentially talking about research. And ideally, we want to inform the decisions you make with high quality or the least biased research available. And the research component is actually really important to remain up to date with practice and ensure that the care you're providing is actually the best for the patient and the service. So if we were to collect information from only one of these 3 key sources, it's likely going to result in a biased or flawed decision and probably won't end up being or providing the best outcome for our patient. There are over 50 different types of biases that influence information you collect from these 3 key sources. And if this is something that piques your interest, I recommend that you go and have a look at the catalogue of biases at the Centre of Evidence-Based Medicine. The reference is just down the bottom. Or refer to the workbook on page 8, where there's a bit of a summary of the more common biases described there. The strength of the evidence-based practice approach, however, is that it's combining the best evidence from these three key sources. And when I'm saying best evidence, I'm talking about the most trustworthy, the most reliable, the most believable, or least biased evidence. And then you're using this evidence from these three key sources to arrive or generate your alternatives and then arrive at a decision. And so we can talk about how to elicit patients' preferences, values, and circumstances. You do this every day. And so you're already masters of this, extracting that information. You're the masters of your trade and have the knowledge and skills to perform your job well. So we don't need to talk about your experiences. But what we are here to talk about today and over the next 4 weeks is how to navigate the research literature and how to incorporate the highest quality or best research evidence into the decisions that you make and into your everyday practice. Very briefly, why is it important to use scientific evidence for research? We know that a research active health service, so one where staff are able to find and use research evidence or engage in the generation of evidence or participate in research activities, results in benefits for the patient and the public, healthcare staff, and the hospital and healthcare service. So specifically for patients and the public, we're talking about improvements in patients' health outcomes and reductions in mortality, improvements in patients' confidence and satisfaction with their care, and overall, patients are becoming more informed about their healthcare and able to make decisions, so they're becoming more empowered. In terms of healthcare staff, we're talking about improvements in job satisfaction, which is great, and this is likely to come in from the fact that you know you're providing the best care for your patients. You're becoming better at critically thinking, so this means challenging the status quo and challenging those treatments or procedures that have always been, and improving the translation of new evidence-based therapies into practice. So again, providing the cutting edge and best care to your patients. Lastly, for the hospital and health service, there's evidence to support that there's improvements in organisational efficiency, reductions in low-value care, such as waste in the service, and reduction in adverse events. And overall, it's building this culture and this culture of quality and excellence that we all want to be a part of. And it's been found to be a good investment, both from the healthcare delivery perspective, but also healthcare quality. Using an evidence-based practice approach is not without its challenges. And some of the common criticisms of evidence-based practice and using research evidence are listed here. So first of all, using research is often seen as a cookbook medicine approach. It's too prescriptive and doesn't pertain to my patient standing in front of me. And I dare say that the solution to this is evidence-based practice. As we've already seen that based on the definition of evidence-based practice, it involves combining information from three key sources of information. So if anything, your decisions are becoming more patient-centred and tailored to the individual while considering the resources and your individual skills. A second challenge or criticism is often reporting that keeping up to date with the literature is often quite difficult. And we know that there's a tsunami of literature being published and not all of it's of good quality and really should be informing our practice. Again, dare I say, the solution is applying an evidence-based practice approach. And as you'll see in week 2, we're going to learn how to target your search for information to the databases that will most likely be of most benefit to you and your search for evidence-based information or the research. Another common criticism, research provides an average I treat individuals. The solution is an evidence-based practice approach. And in session 4, we'll have a look at how results are reported. And in fact, while they do give you an average, they actually also give you a range of expected outcomes. So having the knowledge and skills to interpret that information and then communicate it with patients, you'll find that actually you're able to much better interpret the research and apply everyday practice. Lastly, you require the skills to implement evidence-based practice. And this one is absolutely true, but you've taken the first step because you've attended this seminar series. So over the next 4 weeks, we're going to have a look at the 5 steps of evidence-based practice. So evidence-based practice is triggered when you realise that you need to make a decision and you're faced with a problem or uncertainty, and you don't have the high quality, trustworthy, reliable, or up-to-date information that you need to make that decision. And so the first step you need to be able to do is convert that problem or uncertainty that you're facing in that clinical scenario into an answerable and well-defined clinical question. So you need to be able to ask that question. And that's what we'll be looking at a bit later today. Once you've been able to ask that answerable clinical question, you need to be able to find the evidence or high quality research that's going to answer that clinical question. So you need to be able to acquire the high, robust information. Once you've found that information, you need to be able to appraise that evidence for the validity, impact, and applicability to your situation. You need to apply that information in terms of interpreting it and then again understanding what those figures and numbers mean. And lastly, you need to assess that your ability to undertake steps 1, 2, and 3, and 4. And also consider how you can better implement research evidence into your everyday practice. This diagram is actually a really nice way of showing how important step 1 is. Focusing on step 1 and being able to ask an answerable and well-defined clinical question is actually, dare I say, the most important step in the whole 5-step process, because steps 2, step 3, step 4, and step 5 all stem from having a really good foundation and asking a good, answerable clinical question. So overall, to practice evidence-based practice, you need to have specific knowledge and skills. So specifically to formulate, have the skills to formulate a well-defined and answerable question using the PICCO framework, which we'll take a closer look at today. You need to have a knowledge of the best study designs to answer your clinical question, also a knowledge of how and where to find the evidence. You need to have the skills to be able to assess the believability and usefulness of the evidence, the skills to apply and interpret the findings, both in terms of the statistical significance, but also their clinical importance to your patient and population. And lastly, the skills to just sit back and reflect on how well you can perform those steps, but also have the knowledge of how you can become better incorporating evidence into your research, into your everyday practice. So let's get into it. Let's take a closer look at step 1 and how to ask an answerable clinical question. So as you join us on this journey and over the next 5 weeks, I'm going to stop and sort of pause before each session and really focus on why this step is so important. Because if you understand the why, you're more likely to retain, recall, and use this information in your everyday practice. Why is asking an answerable question so important? I want you to have a think about the last time someone asked you a long, vague, convoluted question. And you know that they've asked you a question because there was that inflection in their voice and that look of anticipation on their face as they paused and waited for you to give the answer that you were waiting for. And then on your side of the conversation, you're trying to struggle through to understand what was the question that they asked and what's the answer that I can provide them with. So this is an example of a poorly worded question. And if you were to draw it, it might look something like this. The person asking the question goes through this big process and you're ended up somewhere along the way with some sort of result. And it might actually not align very well with the question that they're asking. So when we start our evidence-based practice journey, we want to make sure our question is well defined and specific, as only then will it be answerable. And as I highlighted in the previous slide, every step of the process stems from a well-designed and specific question. So in evidence-based practice, we use the PICCO framework to guide the development of a well-defined and answerable clinical question. We're going to have a bit more of a closer look at what PICCO means. So PICCO stands for Population, Intervention, Comparator, and Outcome. And depending on the type of question you're asking, determines which of these elements are important to define in order to ask an answerable clinical question. So P is for population. So who's your question about? If you're thinking about that patient standing in front of you, how would you describe that patient if it was in a group of patients similar to this one? So you could define or describe that patient based on their age. Was it a child? Was it an adult? You could be more specific and provide details in terms of the age specifically that you're after, so over 65s or over 18. You could describe that patient based on the condition that they're presenting with, or perhaps the chronicity of that condition was an acute or chronic condition. Ideally, you want to think about describing your population in as much detail as possible. The I stands for treatment intervention, for treatment questions, and the I stands for intervention. So what's the treatment or management strategy you're considering? We often define the intervention as the new treatment that you're wondering if it's effective. So what's the new treatment you're looking to implement into practice? Depending on the research question, the I can also stand for index test if you're asking a question about diagnostic test accuracy. So the index test again is this new test or assessment that you're looking to implement. And if your question relates to risk or prognostic factor questions, the I stands for indicator. So what's the indicator of interest? An example might be, is age, does age predict a person's recovery of aphasia after a stroke? So the indicator in this instance was age. C is for comparator, so what's the alternative that you're going to compare the intervention or the index test to? And O is for the outcome. So what's the desired or potentially undesired outcome that you're interested in? And it might be from the perspective of you as a healthcare professional, but it might also be the perspective of the patient or their family or the healthcare service. So I mentioned a moment ago that the PICCO element that you need to define depends on the question that you're asking. So let's now have a look at the different types of questions you can ask. So listed in this table are the different types of questions that you can ask. Put them here. And in the next column to the right is just a brief description of each of the questions, different types of studies that you can do or questions you can ask. So qualitative questions often around understanding people's thoughts, feelings, opinions, or experiences. And that might be of a specific test, a treatment, a contact with the health. A frequency or prevalence question relates to how common something is, and that might be a disease, a risk factor, or an outcome of interest. The diagnostic test accuracy questions, you're interested in finding out how well a diagnostic test or your assessment performs against something else. So it's usually what usual care is, or standard care, or a gold standard. In terms of prognosis, we're interested in what happens to people over time. So it might be around who develops a condition over time, or what patients are often quite interested in is what's going to happen to them once they've been diagnosed with a condition. So what's the course of that condition over time? Is that person likely going to get better, remain the same, or are they likely to get worse over time? And so these types of questions are called descriptive questions. What they're doing is really describing the landscape of the current environment. It's often a good place to start when you're looking to understand your patient population or the service that you're providing. Sometimes we want to go beyond just understanding the population, and we actually want to figure out what happens in the future. So we want to predict what's going to happen to someone in the future. And these are called risk or prognostic factor questions. And so we're using information that's available to us now to predict what's going to happen. Is that person going to get the disease or have the outcome of interest? And finally, sometimes we're interested in causation. So treatment effectiveness, what we really want to figure out is the treatment we're providing, does that work? And so the treatment is the intervention, and we're comparing it to another treatment, so usually a placebo, a control, or some sort of alternative treatment. It might be standard care, minimal care, or no care. So I'd like you to reflect on your practice for a minute and determine what types of questions do you most often ask. And a poll is about to pop up. Have a look in your chat function, or it might pop up on your screen. And I want you to consider, what types of questions do you most often ask in your everyday practice? Everyone finding the chat? So it's either in chat or it might pop up at the top of the screen or the bottom of the screen. And so we're getting a fair few, around a third of people are responding to say treatment effectiveness. So they're often asking, is this treatment that I'm providing effective for my patient? And the second type of question people often ask is around a qualitative question. So understanding people's thoughts, feelings, opinions, or experiences. Excellent. And those numbers are looking to stay. So treatment effectiveness questions, which is great, and qualitative questions seem to be the ones that are most often asked. And that's similar to other times we've run this seminar, which is good. So I know this looks like a really busy slide, but we're going to talk through it together. So as we've just seen on the previous slide, you've got your list of questions here, the description of the types of questions you're going to ask. And then over on the right side, we've got the PICCO framework. And what I'd like you to just pay attention to is that the relevant elements of the PICCO framework depend on the type of question that you're asking. As you can see, there's only the relevant elements of the PICCO framework are these ones highlighted in grey. So if your question was one that was related to qualitative questions, so around understanding people's thoughts, feelings, experiences, a frequency or prevalence question, or a prognosis question, in order to ask an answerable clinical question, you need to define the population and the outcome. If your question related to risk or prognostic factors, you need to define the population, the indicator of interest, and the outcome. And lastly, if your question relates to diagnostic test accuracy or treatment effectiveness, you need to define all 4 elements of the PICCO framework in order to ask an answerable clinical question. So if that is the diagnostic test accuracy question, you need to define your population, the index test, so the new test or assessment that you're looking at determining how well it works, the comparator, which is usually standard care or a gold standard, and the outcome. For treatment effectiveness questions, we're looking at defining a population, the intervention, which again is the new intervention that you're looking to implement, the comparators, that's usually the standard care that you're already providing, and the outcome. So in the next few slides, we're going to take a closer look at the different types of clinical questions you can ask. We're going to identify the relevant elements of the PICCO framework, and we're going to take it one step further and have a look at the best primary study design that you would use or search for in order to answer your clinical question. And when I'm talking about best primary study design, what we're talking about is the methods that you potentially in a future date or researchers would use to collect the information to answer that clinical question. So let's start with a qualitative question. So these types of studies, again, are looking to understand people's thoughts, feelings, opinions, experiences about a test, treatment, or healthcare contact. Down the bottom here, we've got 3 examples of qualitative questions. And what you can see, in order to ask a well-defined and answerable qualitative question, you need to define the population. So in question 1, this might be around breast cancer survivors. In question 2, nurses are the population. And in question 3, patients who present to ED. And you also need to define the outcome of interest. So people's experiences around cancer-related fatigue, exercise and exercise adherence, experiences of caring for dying patients, and lastly, people's satisfaction with the quality of care that they receive. And you can see that each of these 3 questions contain the necessary or relevant elements of a well-designed and answerable question. And the best primary study designs to answer these types of questions is the evidence from a focus group, one-on-one interview, or the open responses from something like a feedback survey. It's related to frequency or prevalence, so how common a disease, risk factor, or outcome is. In order to ask a well-defined and answerable question, you need to define the population, the adults, patients following knee replacements, or patients hospitalised with COVID-19, and the outcome, for those who smoke or vape, revisions within 1 year, or how common depression and anxiety is. And when thinking about things like this, the population, some of these examples could actually be improved by adding more details about the population. So again, when you're talking about adults, are you specifically thinking about those who are over 18? Or you may be considering older adults, so those over 65. So again, trying to think or add as much detail as possible about the characteristics of your population of interest. So the best primary study design to answer questions related to frequency or prevalence comes from the cross-sectional study, sometimes referred to as a snapshot or a snapshot study. And so in a cross-sectional study, ideally you'd identify a population of interest, but it's not often feasible to collect information from that whole population. So what the researchers do, or what you would do, would be to take a sample of that population who's representative and at one point of time ask them about their health behaviour or their condition or whatever it is that outcome of interest you're interested in. If your question relates to diagnostic test accuracy, so these types of questions are around how well a new test or assessment identifies people with or without the condition of interest, the relevant elements of the PICCO framework are the population, the index test, so the new test, the comparator, which is standard care usually, or the gold standard, and the outcome of interest. And you can see that the 2 example questions include these 4 elements of the PICCO framework. So that would be suggested to say that these are a well-defined and answerable clinical questions. The best primary study design to answer questions of diagnostic test accuracy are a special type of cross-sectional study. And the aim of these cross-sectional studies is to determine how well a new test or a new assessment identifies people with or without the condition compared to the gold standard or the reference standard. And so in these types of studies, what the authors would do would be to identify a consecutive or a random sample of people who are at risk of the condition of interest. All those people would then receive the index test, so the new test or assessment that you're interested in. They also would receive the gold standard, sometimes referred to as the reference standard. So again, this is the gold standard or usually the usual care that's being provided. And then you would compare the results of test A to the gold standard to determine how well test A performs in identifying people with or without the condition of interest compared to the gold standard. If your question related to prognosis, so again, what happens to people over time, or what's the course of their condition, you need to define the population and the outcome. And the best primary study design to answer questions of prognosis is the cohort study. So in a cohort study, you start with a defined population of people who are with a similar health state and a similar stage of their condition. You then follow them up over time to have a look at who develops the outcome of interest and who doesn't develop the outcome of interest. And that outcome might be a development of a disease, a condition, or it might be some sort of health event like a stroke or a heart attack. For questions related to risk or prognostic factors, they're relevant elements of an answerable clinical question, the population, the indicator of interest, so the person's age or what factors predict readmission to hospitalisation, and the outcome. The best primary study design to answer questions around risk or prognostic factor questions is again the cohort study. So again, the population's identified as a defined population, and the people included are have a similar health, a similar stage of their health condition. A whole pile of information is collected at baseline. So this information is then used to predict. So that might be so the information you collect, it might be the first time you meet them, or then you use this, then you follow up everyone over time, and then you have a look at who develops the outcome of interest and who doesn't develop the outcome of interest. And so you use this information that you collected at baseline to predict who develops the outcome of interest and who doesn't develop the outcome of interest. Lastly, we've got our treatment effectiveness questions. So these questions relate to, does this treatment work? And so the relevant elements of the PICCO framework are the population, the intervention of interest, the comparator, which is sometimes usual care, it could be minimal care, it could be placebo, it could be no care, and then the outcome of interest. Again, you can see in the example questions that these questions include all 4 elements of the PICCO framework. The best primary study design to answer questions related to treatment effectiveness is the randomised controlled trial. And you'll hear me come back to this multiple times over the 5 weeks, that the best study design to answer your clinical question on treatment effectiveness is the randomised controlled trial. And so in a randomised controlled trial, you identify people based on inclusion and exclusion criteria. The people who meet those criteria are then randomised to receive either treatment A or treatment B. And the whole process, the whole point of randomisation is to result in 2 equal groups on all known and unknown factors. So then once people receive the treatment they've been allocated to, you follow up those people over time. And because these 2 groups are equal on all factors, any difference in the outcome is likely the result of the treatment that they received. So this is the best study design to answer questions, is one treatment better than the other? So coming back to this table, hopefully it makes a bit more sense now in terms of the relevant elements of the PICCO framework that are necessary to ask an answerable clinical question. And as we've seen, the relevant elements of the PICCO framework depend on the type of question that you're asking. If that question is descriptive, predictive, or about causation, so treatment effectiveness. We're now going to put into practice some of the information that we've just learned about. So in this hypothetical scenario, you're discussing evidence-based practice with a colleague, and the need to only implement proven interventions. This conversation takes an unexpected turn when you begin talking about the effectiveness of parachutes in reducing death and major injury in adults who jump from an aircraft. So using this hypothetical scenario, what I'd like you to have a think about, and you've got this template on page 12 of your workbook, who's the population, who's the intervention, what's the intervention, what's the comparator? You might need to be a bit inventive with the comparator. I'm happy for all out there suggestions. And what's the outcome of interest? I'll just give you a minute or two to have a think about that. Okay, how are we going? Ready to give it a go? So does anyone want to be brave? Feel free to put it in the chat or put the answer out there. Who do we think that the population is? So I'll go ahead and respond. Hope you enjoyed the animation. So I thought the population in this hypothetical scenario was adults who jump from an aircraft. Fantastic. I'm seeing lots of comments in the chat about being adults. Excellent. Well done. The intervention, any thoughts on the intervention? You're talking about the intervention being the new treatment. Yep, the parachute, fantastic. People are getting it. Great to see. The comparator, I'm hoping for some creative comparators here. Anyone got any thoughts about the comparators? Excellent. Someone said no parachute. Great. In terms of, I guess, credibility, we might want to use something like an empty backpack that kind of looks like a parachute, but it's not for those poor souls. But that's good. And then for the outcome, I was thinking around reducing death and major injury. So now that we've identified the relevant elements of the PICCO framework for a question on treatment effectiveness, we convert that into an answerable clinical question. And so the question might read something like, in adults who jump from an aircraft, is a parachute more effective than an empty backpack in reducing death and major injury? Question mark, because we're asking a question, don't forget that question mark. I know as clinicians, you have lots of amazing questions running around your head every day. So in the workbook, which please find, it's been in the emails, and have a look in the chat as well if you haven't been able to access the workbook. On page 13 of the workbook, there's some templates there to get you thinking about, to writing down your clinical questions, and then thinking about if it includes the relevant elements of the PICCO framework. So that brings us to the end of session 1 today. And just a brief recap. So today we've defined what evidence-based practice is, and I hope you now recognise that actually taking an evidence-based practice approach means that you're combining the best current evidence from 3 key sources: your knowledge, skills and experience, the patient's values and preferences and situations, and not most importantly, but it also incorporates the research evidence. We found out that there's lots of benefits for a research active health service, both for the patients and public, healthcare staff and the healthcare service. We've identified that there's various types of clinical questions that you can ask. These might be descriptive questions, predictive questions, or around causation or treatment effectiveness questions. We've introduced this concept of the PICCO framework that you need to be able to ask an answerable clinical question. And the relevant elements of the PICCO framework that you need to define in order to ask an answerable clinical question might be different depending on the type of question that you're asking. And so if any of this is you need to refresh, it is in the workbook. Just to let you know that you've made it through the first session, the first step in our evidence-based practice journey. Next week, we're going to move on to step 2, how to acquire or find the relevant evidence and high quality evidence to answer your clinical question. We're going to have a look at how and where to find this evidence and the sources of support that you've got available to you as healthcare professionals. So we look forward to seeing you next week, and we hope you can continue your evidence-based practice journey with us. Is there any questions?
So thank you very much, Zoe. What I've done is I've unmuted people so we can take some live questions if anyone's got them. While people are thinking of their questions, I did include a link to our standard RETCAP evaluation survey. We've been using it all year through the RR-CLaN sessions. If you could let us know how we did, that would be great. If you've got any questions, just put your hand up and we'll try to get to you in the order that you've put your hand up. Mitch.
Yeah, I came a little bit late. Sorry for that. But you said that it's being recorded. Where do we go to actually rewatch it? Is there a link already in the emails?
Yeah, so we post all the recordings on YouTube, and then we'll send an email to everyone that's registered, even if they couldn't make it today. We'll send an email to all those that registered with a link to that YouTube recording.
Okay, thank you.
Any other questions?
A bit of a shout out if you haven't registered for the follow-up sessions. We will keep you posted. We've had to transfer to a new platform this time around, and we're still ironing out some creases. So thanks for your patience with the registration process, but hopefully you get all the information you need.
Sounds good. Thanks, Zoe. So it seems like there's no more questions. So what I'm going to do is thank you, Zoe, for a very informative presentation. Thank you all for attending. I'll draw the session to a close, and hopefully we'll see you guys for session 2 next week. And I think Kimberly's got her hand up, or not.
No, I'm trying to turn it off.
That's okay, Kimberly.
Sorry.
It doesn't matter. Thank you all for attending today. We'll see you next week or on a subsequent
Thanks,
session.
everyone.
Enjoy the rest of your afternoon. Bye-bye.
Great. Thanks so much. Bye.